Welcome to this meeting of the London Assembly, when today we're discussing the draft Health Inequalities Strategy. Have we any apologies for absence?
We have apologies, Chairman, from the Deputy Chair of the Assembly, Jeanette Arnold, Assembly Member Dismore and Assembly Member Whittle.
Thank you very much. I have a few announcements. On behalf of the Assembly, I wrote to the Regional Governor of Attica to express our deepest sympathies to the people of her province affected by the dreadful fires in Greece in July. On behalf of the Assembly, I would like to extend my condolences to the family of the former chairman of the GLC, Bernard Brooke Partridge, who passed away in July. And I would also like to extend our condolences to the family of Sir Alan Greengross, who died in August. My colleagues are getting fewer and fewer. Can I provide a brief update on some of the Assembly's recent activity? Over the summer, the Environment Committee launched its report into single-use plastics like wet wipes, nappies and sanitary products. Many people flush these down the toilet, and the committee wants the government to improve the labelling to help consumers, and also to consider a ban on wet wipes that contain plastic. It called on the Mayor and the boroughs to work with Thames Water in tackling this issue. In addition, the Transport Committee wrote to the Mayor calling on him to make a better use of the River Thames as a piece of London's transport network, made a number of recommendations, including the creation of a river ambassador to provide the leadership needed to promote passenger services on the river. Finally, the Police and Crime Committee published its report on women in the criminal justice system. It highlights the challenges created by sending women out of London to serve what are often short sentences, and the need for more confidence in community sentences. It asks the Mayor to build on his work with the Ministry of Justice on devolution to improve outcomes for women who offend and for those at risk of offending. May I ask the Assembly to note the recommendation set out at item 2?
Agreed.
Thank you very much. In addition, do members have any other declarations to make which are relevant to the items on the agenda for today's meeting? Okay, thank you very much. May I ask the Assembly to agree the minutes of the London Assembly plenary meeting held on the 5th of July 2018 and of London Assembly Mayor's Question Time meeting held on the 19th of July to be signed by me as a correct record. Thank you very much. And now to today's meeting, which is, as I've said, is for the Assembly formally to receive, in accordance with section 42B of the Greater London Authority Act 1999 as amended, to consider the Mayor's draft Health Inequalities Strategy. Can I welcome to today's meeting our guests, Sadiq Khan, the Mayor of London, Professor Yvonne Doyle, CB, Statutory Health Advisor to the Mayor, and Dr. Tom Coffey, OBE, Senior Mayoral Health Advisor. Welcome to you all. I will begin by asking the Mayor for an opening statement regarding the draft strategy. The Assembly will then receive an opening statement from Dr. Onka Sahota, Chair of the Assembly's Health Committee. After the opening statements, the Assembly will put questions to the Mayor on his draft strategy for up to 1.5 hours. There is one lead-off question for this session from me as Chairman, and Assembly members may ask supplementary questions after that question has been answered. Mr. Mayor, would you now like to make a statement?
Good afternoon. I'm delighted to launch the London Health Inequality Strategy today and to have this opportunity to answer your questions along with Professor Doyle and Dr. Coffey. London is the greatest city in the world. Yet like other global cities, we face some big challenges. One of the most pressing is the stark health inequalities that prevent many Londoners from fulfilling their potential. We know that far too many Londoners are still suffering ill health because of social and economic exclusion, and that good health can vary massively from borough to borough and postcode to postcode. Evidence shows that people in low-income households are 2 to 3 times more likely to develop mental health problems than those in the highest income households. We know that the most deprived children in London are more than twice as likely to be obese compared to the least deprived. And studies have shown that boys born in Kingston upon Thames can expect to live around 13 years of their lives in poor health, whilst girls born in Tower Hamlets can expect to live 27 years, a third of their lives, in poor health. This is simply not good enough. So at the heart of this new strategy, and as part of what we're doing at City Hall, we're working to create a healthier, fairer city where nobody's health suffers because of who they are or where they live. We've received, Chair, a fantastic response to the consultation from Londoners, businesses, local councils and community organisations from across our city. I want to take this opportunity to thank the Assembly's Health Committee for their valuable scrutiny and input, which has improved our strategy, and to Dr. Onka Sahota, the Chair of the committee in particular. This health inequality strategy sets out some big and bold ambitions for our city. This includes helping families ensure a healthy start in life for their children, particularly in the most deprived communities, tackling the stigma people still face around mental health and providing more support, ensuring greater access to green spaces and tackling air pollution so all Londoners can benefit from a healthier environment, empowering Londoners to act on the things that affect their own community's health and well-being, and making sure the healthy choice is the easy choice for our Londoners, whether it's healthy food or cycling across our city. Crucially, this strategy has been developed in tandem with our other strategies, including transport, the environment and housing, because we must always remember that health is part of a much wider picture. We still have a long way to go, but we've already made some good progress from the Healthy Early Years London programme to rolling out mental health training to all schools. I'm confident that this strategy lays out deliverable plans to make London a healthier and fairer city and will help us to improve the lives of Londoners both now and in the future. But I'm afraid, Chair, I can't finish without highlighting the enormous and unsustainable pressures currently facing the NHS, council services and public health provision, crucial partners in reducing health inequalities. Services are massively stretched. Waiting times are on the rise, and cuts to local government funding, including the public health grant, threaten to undermine the success of our programmes in London, putting people's health at risk. We owe a huge debt of gratitude to everyone who works in the health and care sector. But the truth is that without the government stepping up to the plate and providing the funding our city needs, tackling London's health inequalities is going to be much harder. That's why I'm calling on the government to use the upcoming spending review to reverse its cuts to the public health grant and publish the green paper on adult social care so that we have the resources and powers we need to improve the health of our city. I look forward to answering the Assembly's questions.
Thank you very much, Mr Mayor. Assembly Member Sahota.
This Assembly shares the Mayor's aspirations for London to be a global leader on the health and well-being of its citizens, where no one's health suffers because of who they are, how and where they live. We know that London remains a city which has profound in health inequalities. And we know that the health and care systems in London, as elsewhere, are under considerable stress. This is why it's vital that the Mayor exerts strong and sustained leadership through the health inequality strategy. The Health Committee's primary concern throughout the scrutiny process has been to ensure that bold vision for tackling health inequalities in London is matched by specific, measurable and concrete plans to put into action. We have met with a range of experts in the field and with the Mayor's health advisors to try and ensure that the final strategy rises to the challenge and sets out a clear roadmap for improving health of the most vulnerable Londoners and reducing health inequalities. We are therefore pleased that the revised strategy has taken on board many of our key recommendations, including more stretching targets for childhood obesity reduction and improving the health of early years, a strong emphasis on reducing health inequalities and between different groups and communities, clear direction for partners for where the Mayor expects and what the Mayor expects from them, and concrete pan-London action on suicide prevention, specific measures for community engagement and strategy. It's absolutely vital that the implementation of strategy is properly monitored and evaluated. The committee welcomes the Mayor's agreement to publish an annual report on the progress of the strategy and a dashboard for performance indicators that are accessible to Londoners. Nevertheless, there's still questions to be answered and how the Mayor will hold his partners to account. to play its part in a unified strategic response to health inequalities in London. And the Mayor must also challenge the health and care systems to provide timely and equitable access to London's need. Effective mayoral leadership would be critical for the success of the strategy. In particular, the Mayor must harness opportunities to improve health throughout all of his work, and not just through the health programmes, but through transport, environment, housing and planning, using health in all policy approach. If there is a broad commitment and sustained effort, the health inequality strategy is a real opportunity to improve social and economic prosperity in the capital and boost the quality of lives of millions of Londoners. That is why it's important that we get it right, that we are ambitious, that we continue to keep the focus on the important issues. I commend the strategy to the Assembly.
Thank you very much. I now come to my lead-off question to the Mayor, which is, what has been done to strengthen the draft health inequalities strategy as a result of public consultation?
Thank you, Chair, for your lead-off question. As I mentioned in my opening, there was strong support expressed in the consultation for the vision and policy direction expressed in the draft strategy. There has been some strengthening of the narrative to ensure clearer cross-referencing across this strategy and with my other strategies as they have developed, as was alluded to by Dr. Sahota. We've also responded to some specific suggestions from the Health Committee and others. For example, strengthening the narrative throughout about the role of poverty and income inequality in health, reflecting the needs of older Londoners, highlighting the links to other GLA strategies and programmes, and reflecting the cross-theme nature of issues such as mental health, providing updated information on GLA policies, projects, programmes and strategies, for example, the Young Londoners Fund, Healthy Early Years London, Good Work Standard and housing, providing updated information on health and care devolution. Some important additions have also been made, Chair. These include adding an objective on older children and young people to healthy children, adding the addition of commitment to dementia-friendly London in healthy communities, adding objectives specifically on physical activity and food, including the ambition on reducing physical inactivity to healthy living, updating action and commitments regarding child obesity, including the convening of the London Child Obesity Task Force, and new targets and ambition, and the commitments consulted on in the draft food strategy and the draft London plan. There are amendments and new sections on the role of partners in health inequalities and delivering the strategy, and specific asks of partners, including government, something the Health Committee asked for. These include a new section in the introduction outlining the role of key partners in London health inequalities, amended sections on how we will work with partners in moving the strategy forward, a new section on the role of the health and care system specifically, and the Mayor's priorities in terms of their action on health inequalities, a new sections at the end of each thematic chapter summarising mayoral commitments and my specific asks of partners. And finally, Chair, I have provided an implementation plan setting out the priority actions we will take over the next 2 years and beyond, working with partners to deliver the strategy and a series of key performance indicators to monitor progress towards the key ambition. It also outlines some priority areas for partner leadership where we want to see some action. The plan also includes a set of population indicators through which we can monitor the picture of health inequalities in London in the longer term, and the implementation plan will be reported on and updated annually.
Thank you very much. Assembly Member Berry.
Thank you very much, Mr. Mayor. I wanted to talk to you about green spaces initially, if that's okay. The draft strategy here talks about protecting green spaces, objective 3.3. It doesn't mention the fact that 50% of London suffers from a deficiency of access, or it does say there are areas of shortage. But it's really important to get those numbers in there, I think. As objective 1.2 notes, green space helps support children's health and well-being. It could also mention that it helps support their learning. So what I'm concerned about here is how the strategy will not just protect but increase green space, particularly to address the worst deficiencies. I think you have to be focusing on the areas of greatest need. And the strategy talks about, in the implementation part, it talks about using the draft London plan. But I wonder if you could talk about how you could make the implementation of this objective more strategic, in particular around your funding and grant systems, to actually focus on those areas of deficiency.
Well, thank you for your question and for your comments. You'll be aware that in the recent environment strategy we published, we had in there funding to back up our ambitions, not just to keep what we have that's green, but to expand that with urban greening, with the green infrastructure funding as well. Roughly speaking, 47% of London is green. We're going to keep that and increase that to 50% going forward, and you'll be aware, and you've supported our ambitions to be a national park city. One of the things that we're seeking to do is make sure in those parts of London which have a deficiency of green spaces, we can use urban greening to provide more green spaces there. You're right, the Draft London Plan talks about this. And we also have increased funding hugely to plant more green trees. I'm more than happy to go and look at how the implementation plan can demonstrate the progress made over the coming period. You will, I'm sure, support some of the plans we've got around greening in the environment strategy, in the Draft London Plan. And so if there are ways that we can show the success going forward, I'm more than happy to look into that in the implementation plan. Professor Doyle chairs the London Prevention Partnership, and what they will be doing is monitoring and reviewing progress on the plans. I'm more than happy for Professor Doyle to be more specific in relation to how we can monitor the progress, which is your question.
Thank you. Thank you.
Oh, just be aware, I'm very short of time. The Mayor is used to this, but I might try and cut you off if you talk for too long. I'm on a stopwatch here.
just to assure you that I will, and there are opportunities coming up in the design of London through Healthy New Towns and other initiatives where we would keep this in mind about greening.
Yeah, particularly the grant schemes, just to make sure that the people from all areas are applying, particularly areas that are deficient. That's one of the things that concerns me. I also wanted to talk about older children. My response to the draft pointed out that there was basically a big gap, no objectives around older children, teenagers, young adults. And I think this was the result of the timing of the strategy, because it came out before you decided to put investment into young people, before you worked on a more public health approach to crime. And I think all this work, the public health approach, it's about promoting health and well-being in young people. It's not just about reducing violence, and we needed objectives on this. So that's good. I'm pleased to see it. Objective 1.4, it goes much further than early years. It talks about some of the measures you're taking to support older children and young people. So can you say a bit more about how you're going to measure progress on that? Because it doesn't feature in the list of outcomes measures. And I'd be very interested in knowing how we can measure how younger people, older children, are thriving in London, rather than just focusing on crime.
Thanks for your question. One of the things that the integration team's been working on is to measure just that, how we can measure properly, not just participation, but actually the level of participation when it comes to sports, other activities that can get young people engaged. You'll be aware, and you've supported, and I appreciate the support, the increased funding to a new Young Londoners Fund over the next 3 years, but also Sports Unite, how we can use the £8 million of funding there, not simply to get young people playing sports, but also how it can lead to better integration, leads to closing the gap between health inequalities that currently exist, but also make sure that young people work with older people, the coaches are older people. It's a good way of dealing with issues I know some members of the Assembly have around older Londoners, making sure they're involved in policies to address health inequalities. Once again, Professor Doyle is in charge of this area, and I'll let Professor Doyle deal with the issue of how we're going to measure how the monies we're invested is being utilised. One example, a crude example, of course, is the work our community engagement team does with young Londoners. We're seeing more and more young Londoners involved. We'll shortly be announcing the second tranche of successful bids for Young Londoners Fund. I'll let Professor Doyle deal with how how it will be monitored. By the way, Professor Doyle's board will be on a quarterly basis doing a deep dive, and so it won't simply be once a year, it'll be quarterly as well.
Okay.
Would you like me to add to that?
If you like, yeah.
Sian? We will indeed do that. The other area that we work a lot with is healthy schools, where we look at both how children are doing in schools, but now increasingly how they exit school into the workplace. And there are programs here through the GLA, but also through other partners locally about how many get into the workplace, how their skills and apprenticeships are improved. So we do measure this and can offer these as measures as this strategy develops.
Okay, that'd be really useful. So finally, I wanted to ask about the fact that the Assembly's resolved to consider the impact of Heathrow expansion in all its work. This strategy seems to be a place where Heathrow will have a big impact on health inequalities, things like heat waves, extreme weather caused by climate change, but also noise, particularly air pollution and traffic locally. So it's a shame there's no comment at all on Heathrow in the strategy at all. So will you look at Heathrow expansion impacts for all your strategies in future, Mr. Mayor, and make amendments to them?
Every single bill strategy.
We've resolved to do much the same as an Assembly, yes.
Well, look, I mean, at the moment Heathrow's not happened. Clearly we want to make sure that when it comes to the concerns we have, they're addressed. When it comes to the court case, that you'll be aware we are supporting with the local authorities that the Chair was a passionate advocate for. And so you will see over the course of the next few weeks and months some of the work that's taken place in the court case, which addresses some of the issues that you've alluded to, the concerns there is around air quality, you mentioned heat, other concerns that we have around Heathrow. Clearly, the expansion hasn't happened, so we can't post-event look at the impact of the expansion. But I understand your question. What I think we wouldn't do is go back and revise every single strategy we've published. We've already published a housing strategy, environment strategy, and a transport strategy. But I take your point to make sure that Londoners are alive to the concerns that many of us have, should Runway 3 proceed.
Excellent. And also city airports as well?
In relation to the expansion of city airport.
In relation to its health impacts on the people living there.
Sure. I mean, it's worth important just to say that the expansion of city airport is not in the same league as the expansion of Heathrow Airport. There are some concerns that have been expressed, not just by Newham Council, but residents in and around the area where city airport is in relation to expansion. And of course, I'll make those points quite firmly should there be an opportunity for me to do so.
Okay, thank you very much. We're out of time. Assembly Member Sahota.
So thank you, Mr. Mayor. Is the objective of the health inequality strategy to improve the health of the population of London, or is it to reduce the inequalities between specific groups of Londoners?
Well, you'll be aware, Dr. Sahota, that one of the reasons why Parliament decided that a mayor must have a health inequality strategy was to address the issue of health inequalities and to narrow the gap. And quite clearly, our focus should be on reducing the health gaps between different groups of Londoners. It could be around deprivation. In some areas, it could be around gender. For example, suicide, bigger issue with men than women. Depression, bigger issue with women than men. Mental health, bigger issue with younger Londoners than older Londoners. Disability, bigger issue for those who are disabled than those that aren't. So that's the focus. But quite clearly, we also want to see improvements universally. So the best way to characterise it is it's a focused approach, but also a universal approach as well. So what we wouldn't do, for example, is want to see inequality being reduced by those who are healthier being less healthy. What we're going to do is to, of course, the progress they're making, carry on making that progress, but have those who are struggling make progress. Let me give you just one nugget which is worth us all being aware of. The evidence is affluent Londoners continue to be healthy and are making good progress. And we don't want to stop that. What we do want to see target is the entrenched problems there are that you're an expert in relation to your practice, but also what you see every day. Those parts of London where we know healthy life expectancy, quality of life are real issues.
May I just add to that and say some of the projects we've developed have been deliberately done whereby they may have a universal approach, like the early years settings of all 13,000 London early years settings, having a new early years programme, but we're making sure that we're also targeting at those areas of most deprivation. Also, air pollution, we have an impact to try to improve air pollution throughout London, but what we're aware is the poorest parts of London have the worst air pollution. One thing which is perhaps surprising is England has health inequalities, but the worst level of health inequalities is in London.
Yeah, I mean, London does have a huge amount of variation, as you say. And of course, thank you very much for describing universal proportionality, which Professor Marvel applies to the way you should have access to universality, but also target specific groups. So are there any priorities which you want to address in the next 2 years, of any particular specific areas which you want to focus on?
Well, there's a number of, I'll let Tom and Yvonne answer, but there are a number of objectives we've set out in the health inequality strategy you'll be aware of, and you'll be aware in the implementation plan there are a number of focuses that we have. But in relation to some of the stark figures, you'll be aware more than 9,000 premature deaths in London because of poor quality air, and you'll be aware of the progress we've already made in relation to cleaning up the air in those parts of London where we've got the low emission bus zones. T-Charge has begun, ULEZ begins in April. And Tom's point's really important, so I'll give you an example. One of the reports that I made public that had been hidden away was when you saw the most deprived parts of London have the worst quality air. So the air quality audits around the 50 schools in the most deprived parts of London that we published, the audits are targeting those schools, and you'll see hopefully acceleration of improvements in those parts of London around air quality. But I know that Yvonne and Tom have got other examples in the inequality strategy that we've focused on as well.
Okay, so two areas we would probably talk about would be children and mental health. For children, we've already heard about the early years programme to try to almost replicate healthy schools. 80% of schools in London are signed up to healthy schools, and the early years of the 13,000 settings, 1 o'clock clubs, childminders, we're hoping to start from a standing start now and increase that over the next few years, minimum of 10% in the next 2 years. Childhood obesity. Again, looking at children, whereby England does have a problem with childhood obesity. London has a bigger problem than the rest of England, and there is a big difference between poverty and childhood obesity and affluence. Our heaviest children are in our poorest areas, and therefore we need to make sure we have very much a global city-wide approach to childhood obesity, be it about activity, about advertising, about planning, and about diet. The second area, I suppose, we'd focus to say our priority is mental health. You'll have heard of Thrive London. You're very much having a city-wide approach to how do we reduce the stigma of mental health in London, be it at the workplace, be it at school, be it in a wider community. And how do we make sure that we use this improvement in the reduction in stigma in mental health to have improvements in outcomes, reduce suicide, more people with mental health problems staying in work or becoming employed after being unemployed for long times. So I suppose I would probably talk about children and Londoners with mental health problems.
Okay. Thank you.
Thank you very much. Assembly Member Curtin.
Thank you, Chair. Good afternoon, Mr. Mayor. Now, one of your things, you talk about the Healthy Schools London programme, and a lot of good things in there, and you talk about encouraging active travel to school and active play. The school run is something that is increasingly done by families where children are driven to school, so they don't walk to school, they don't cycle to school. Have you got any figures for percentages of children who do walk and cycle to school, and have you got any specific figures as how much you'd like to that to improve in the future? Any specific targets for the numbers of children walking and cycling to school?
No, I won't come in a second, but we have those figures, and you'll be aware of the Healthy Streets programme. One of the questions somebody alluded to was the connection between the health inequality strategy and the other strategies that we have. And this chimes with the transport strategy quite a lot, so you'll be aware of the huge monies TfL is devolving to local authorities. And one of the things we're saying to local authorities in relation to this LIP money is there'll be a bias towards funding being given to encouraging children and parents to walk to school or cycle to school. And you'll have seen before summer one of the examples of a school in Westminster actually, where the council, Westminster Council, local businesses, City Hall worked together with parents and teachers to encourage more and more children and parents to walk and cycle to school. The council managed to, with the school, leverage in private money to green a wall, to turn a school, I think Senator Devonish probably knows about this, to turn a teacher's car park into a garden, to encourage cars not to idle outside, but also when the school starting day and the school finishing day, the council had brought in a scheme where cars couldn't go down that road. And we've got figures for across London. The focus is a question that Dr. Hota alluded to, is prioritising those schools with the worst quality air, and that's where the money's following the audits and stuff. But Yvonne, as part of the implementation plan, will tell you more about some of the figures we have.
So, sir, the less than 40% of children do the recommended activity, for the Chief Medical Officer's recommended activity per week of activity, either in bunches or by day. They can do this anyway, and they can, you're absolutely right. It'd be better if they walked to school than they had to do sort of, running races every day or every couple of days. So we would rather it was built into every day. And one of the excellent ways of doing this, for instance, is the Daily Mile, which gets them doing, it's an easy thing. They can work it out with their parents. They can either do it through in the school, and the good, healthy schools get them to do the Daily Mile in the school, or they can do it by walking to school, or both. So we'd like to see more of that. We're working on that through the early years, because we've got to get them interested in hopping, skipping, scooting when they're in the nurseries. And the parents get the idea then that the kids like doing this. Oddly, you'd think this comes naturally, but not anymore for 60%. And it varies in London. So there are certain parts of London, there are certain groups in London who are very inactive. And others, maybe those living near a green space, are perhaps more active. So there are inequalities in all of this.
I would imagine so. And the Daily Mile sounds like a good idea, but obviously getting children to walk and cycle to school would also cut down congestion, so that would sort of cross over with your transport strategy as well. So I mean, anything you can do to say more about that would certainly be welcome. But if I could move on to another area, I mean, another thing that sounds good is you want to take steps to reduce the use of and harms caused by tobacco, illicit drugs, alcohol and gambling. Alcohol, small amount, regulated and controlled is okay, but we obviously have a big problem with binge drinking on Friday and Saturday nights. Particularly you hear that from people working in accident and emergency rooms in hospitals. So can you say any more about the specifics of how you're going to reduce the use of those things and the harms caused by those things?
Well, there's a bundle there, but actually quite often they go together. So there are big in tobacco use. Those in the sort of managerial social class at the highest, most affluent, their prevalence of using any form of tobacco is about 12%, and in the manual groups it's 25%. So a huge gap there. Undoubtedly, e-cigarettes has helped people to quit, because this is an addiction very often. So it is helpful, and it is much more safe than tobacco. So we do encourage that. There are programs throughout London on quitting smoking and quitting tobacco. But much more important now is preventing the youngsters taking it up. So through the Devolution programme, we're working enhancing an illegal tobacco scheme with HMRC and local environmental health, mystery shopping, but also checking out on the back streets, really, where the kids are being sold individual cigarettes. And we have data for all of that. We're collecting that. For alcohol, London does have a binge drinking problem, but less so than other parts of the country, and more young people are abstaining. So it is the region with one of the lowest consumptions of alcohol, but it's still an important thing, and more people are drinking at home. Those who are binge drinking are topping up before they go out, and that's causing enormous problems locally with disturbance and street annoyance and so on. And it tends to cluster. So again, there are programs mainly through local authorities, which I work with very closely on the public health system, to reduce the harm from over-alcohol consumption, particularly at weekends. But clearly we will want to monitor that through the Prevention Board to see how we're doing and whether that's disimproving. We work closely with the NHS on this, and we have a very good alcohol service which works through our own Public Health England service and supports local authorities. Now, gambling.
Can I just
yes?
I'm nearly out of time. I'm just interested in picking up on one of the points you said there. You're saying binge drinking tends to cluster. I mean, have you got specific areas where you know that there's more of a problem, and can you tell us what those areas are?
Yes, we can look at it by group and by borough. Central London is problematic. About 9 or 10% of drinkers who are not drinking the recommended amount binge drink. Others are doing it actually quite regularly, and that is as damaging to your liver, probably more so than the binge. But the binge is awful because it just causes so much chaos and violence and so on. So we do have Central London. I won't name the borough, but there is one borough where there's quite a lot in Central London. We've watched the alcohol statistics for admission to hospital as well. They are lower than other parts of England, but we know what they are, and we can track them, and that's part of our tracking system that we will have for this strategy.
Okay, thank you.
Thank you very much. We're out of time. Assembly Member Hall.
Thank you, Mr. Mayor. I was really very disappointed to see that hepatitis C wasn't adequately covered. And you'll know of my concerns of this because I wrote to you on the 3rd of August. Thank you for your reply, which I received in my inbox today. And in that, you actually say, and I quote, "This is a significant issue which impacts on the lives of many Londoners. It disproportionately affects some of our most vulnerable and excluded citizens," which of course is what this strategy is all about. Why was the issue of hepatitis C not adequately covered in the strategy? It's had 2 very short mentions.
Sure, I'll let the health advisor deal with the specifics, but TB and HIV were the 2 areas that were given more focus than Hep C. And in managed to, you'll have seen that we're going to support the London Joint Working Groups who are doing work on this, which you mentioned in your letter, particularly in relation to the conference held in December, but other work we can do with them as well. But I'll let Yvonne or Tom deal with the issue of, bearing in mind our work on TB and HIV, why we've not got the focus on Hep C that you'd have liked to have seen.
So, Deputy Hall, I concur with your concern about this. I mean, there are still 200,000 people in England, in the UK actually, who have long-term problems with hepatitis C, and there is an ambition to eliminate new hepatitis C by 2030. So we're working very closely, particularly with the NHS, because the solution to this is new antiviral treatment, and that is now available. And actually we have seen a reduction of 11% in new hepatitis C infections recently, and that's very hopeful. But I don't think we can neglect this at all. It is part of our substance misuse programme. It's also part of our health protection programme. We're working very closely together on it, and it will definitely form a focus for our health inequalities implementation, because it is a definite manifestation of inequality. The fact that it isn't fully worded here does not mean that we are not absolutely on top of what we can do about this.
But you see, I don't understand that, because if you are on top of it, surely it should form part of the strategy. If you look at how many people are living with HIV, it's around about 40,000 in London. People living with hepatitis C is around about 40,000 in London. There are some extremely exciting developments. We could make this the first global city to rid ourselves of it. But it gets 2 tiny little mentions here. It's no good us hearing that you're doing lots behind the scenes. You should be putting it in the strategy so that we can keep an eye on it, so that other people are being made aware of what's going on. And it's a massive omission. And it's not as if I haven't highlighted it to the Mayor over a month ago. It really lets down those 40,000 people in London that are suffering from this.
Well, I would disagree with you that we're letting them down. We're actually working on their behalf and working very, very much. But, you know, it's something that we can report on. It's not a problem. We do have the data and we are doing the work. So I think the fact that it doesn't get a whole lot of words in here does not reflect the fact that we aren't actually working for those people. In fact, we have championed exactly what you're describing here. We wouldn't have seen 11% reduction if we hadn't actually pressed hard for the treatment to be made available. And we're working closely, as I say, across several services on that. But I absolutely accept your point. This is a very important group. I would certainly concur with what you say.
Well, with the greatest respect, I've spoken to the groups. They are pushing at a closed door, is what we've been told. It would show everybody that you are serious about it if it featured in here. You say not very many words. There are virtually no words. It gets 2 mentions. Exactly the same number of people are suffering with hepatitis C or in London as are suffering from HIV. On that basis, this group of people absolutely should be in this strategy.
Thank you. And just to assure you, I am meeting some of your colleagues very shortly on this and have been very closely in touch with the Hepatitis C Trust for many years.
So do you not think it's an omission then, that it's not actually in the strategy?
Well, I mean, it's a matter of opinion there. It is there. We are doing the work and we are seeing the progress.
It's not there. Nothing that you say you're doing is anywhere near this strategy.
Well, and perhaps we could have that conversation again, because I think I would certainly personally say that we're doing the work.
And as a clinician, for hepatitis C as a GP, many years ago, the treatments that were offered were very limited and were very debilitating to take those treatments. Over the last few years, the treatments have improved enormously, and the NHS itself has made it a much greater priority, and the funding streams which have been coming through to fund these drugs, has been a focus of national debate over the last 18 months. And often when you have to choose your priorities, well, I would say as a GP working in London that the NHS has given it a much greater priority than it did 10 years ago, and that therefore I would feel that there is a significant London-wide focus on it from the NHS. However, I recognise that for those 40,000 hepatitis C infected people in London, it's still an enormous issue for them and their families. I would happily, as Sadiq's health advisor, meet the groups, the team, to see is there anything else that I recognise, and within the prison service with rough sleepers.
Yes.
And so we recognise these are the issues which the NHS in London is already working on, and that's perhaps why we chose not to put the same focus on it as you would have liked, because we are very much aware that the big issue of hepatitis C isn't just a new treatment which we've heard about, it's actually the undiagnosed cases which will go undiagnosed until we do much more proactive kind of targeted screening.
Yes, but given the new drugs, we could make such a difference in London. We could make a substantial difference in London. You've missed a trick here. We could be the leading global city on eradicating this because of the exciting new treatments. And it's something you've completely left out. And I highlighted it to you at the beginning of last month. It is such a shame that this isn't being put in the strategy as something that we can all achieve, because that's what we're all here to do, make things better for Londoners. Thank you.
Okay. Thank you very much. Assembly Member.
Can I congratulate you? This is a very different document and more focused than was originally before the Health Committee, and I think your team has done well in the way it's presented. I didn't recognise earlier what Assembly Member Berry was saying about the focus not being on young people. I think it is throughout the document, and rightly so. And rightly so, it should be prominent about that. But one of the issues, and I think with the announcement last year about the ageing population, is about what are we doing and how can you describe to me in the strategy what are we working towards in terms of reducing the health inequalities amongst older people?
Yeah, thank you for your comments and your question. I mean, throughout the strategy, healthy minds, healthy places, healthy community, healthy living, clearly less so in healthy children, there is evidence and policies that will help London's ageing population. And it's something I alluded to in my opening statement, which is there's life expectancy, then there's healthy life expectancy. And so many Londoners who live a long life, for a long period of it, they're not healthy. And so what we're trying to do throughout the policy is make sure they can have a longer period of their life that's healthy as possible before they're becoming less healthy. So the examples of the policies across the GLA range of policies we have are policies in relation to integration, social integration, how we can use digital inclusion to get older people to have better services than they currently do. In the transport strategy, how we can have more and more stations with step-free access, how we'll continue the Freedom Pass, which is so important for older people to getting out and about, dealing with issues of isolation, but also dignity as well. Also in terms of housing, so in the draft London plan and the housing strategy, I'm really pleased and proud that we're saying to developers 10% of all new homes need to be wheelchair user dwellings. We're also though making sure that there's a benchmark for specialist support housing, which will become more and more needed as we go forward and as there are advances in science and people live longer. The policy I'm proudest of is one which has not yet borne fruit, which is for London to be a dementia-friendly city. Just think about the sort of more as Londoners age and live longer, the conditions they will have that will need support from other Londoners. And the good news is, whether it's TfL, whether it's the Met Police, whether it's the London Fire Brigade, whether it's the employers, there is a willingness for us to be more dementia friendly, which is so important as we go forward. But, you know, one of the things that Tom's been working on is the area of social prescribing. One of the things you will know is rather than a GP giving a patient a tablet, often the solution to the condition they have could well be signposted to a community group. And Tom has examples of some community voluntary groups that are particularly helping older Londoners, which we want to support.
And so for social prescribing, about a fifth of people who come to see me don't have a medical problem. And often they have a problem which could be addressed by services which are out in society. And the area, and often it's the older population. So two areas I'd focus on. One is loneliness. What we've realised more recently is loneliness, it does not just make you unhappy, it actually has a detrimental effect on your physical health. And many patients come to their GPs, often because of social isolation. So we've started having social prescribing directly to Age Concern, so to Age UK, so they can actually do something about that loneliness. It also has an improved impact for the NHS, the NHS spend, and social care, because people who are engaged in society and less lonely are more likely to stay at home and use NHS resources less. Secondly, is about mobility. Older people benefit enormously, even more than younger people, from staying mobile. Once you start falling as an older person, your likelihood of succumbing to falls is enormous. 30% of people die within a year of breaking their hip if they're an older person. So if we can refer older people to exercise classes, mobility, walks, things that they can't find out themselves, that improves their physical health enormously. So I would argue that social prescribing, more than prescription prescribing, is going to have a bigger impact on the physical and mental well-being of our older populations in London.
Mayor, you rightly said in the London plan there's lots of good things around contributing to this health strategy, and I think some of that is for the first time in a very coherent way. If we can go back to the social prescribing ambitions, where would sort of cross-generation volunteer programmes fit into that? And who is best placed to undertake that work? Because I don't see the health service doing it. I don't see local government doing it. Does that fall to us in our volunteering ambitions? And could we put young and old together to meet some of that social prescribing ambition of tackling some of the inequalities in health?
Yeah, I think we should. I think you make a really good point. I mean, to be fair to the NHS and to local authorities, they do stuff, but clearly there's a role for us as City Hall to lead on this. And we're doing some great work here with Team London and with V Inspired, with the work we're doing in relation to helping people become volunteers. The Good Work Standard is encouraging employers to give employees time off to be volunteers. City Hall is a very good employer. It encourages its employees to be volunteers and gives you certain days where you can be a volunteer. Professor Doyle has looked into some of this now. We can encourage more people to volunteer. And the good news is the person who volunteers benefits as well. We shouldn't assume it's one-way traffic as well.
Yes, and I mean, I accept the point that we definitely need to make it easier for people to volunteer. I think one of the issues is it isn't always easy to find your way into that. And Be Inspired is one of the programmes that's trying to enable that path. Particularly, I mean, we know that 3 times as many people would like to volunteer as actually do, but the trend is downwards, so we definitely have work to do here to make this easier. And I think, engaging with young people's panels and so on, where they are doing terrific work through the schools where we see some of this, we need to keep that going as they get into young adulthood and just help them, get that extra time to do it.
Thank you.
Thank you very much. Assembly Member Pidgeon.
Thank you. You've already mentioned, which I'm really pleased, that you've pledged to make London a dementia-friendly city by 2022, but your strategy doesn't actually have that many references to dementia within it. I'm wondering, will you consider appointing a dementia champion in your office in order to ensure action is taken and make sure that London does become this wonderful thing, a dementia-friendly city?
I don't see a reason why we wouldn't, if it will help move this forward. I did the training. And it is eye-opening because you think you're aware and you go in the training. And also we hosted an event here a few months ago which was fantastic. And so I looked towards Tom and Yvonne about
and so for a city to be dementia friendly, one initially thinks about just transport. How can we make sure our bus drivers, our tube staff, but in fact you realise that for businesses, how do you make sure all the businesses have staff who are aware how to deal with a person with dementia? Our tourism industry will improve, our business will improve. We make sure London is seen as the first dementia-friendly capital.
So will it help then to have a champion to
I think
bring
it would.
all that together?
Can we go and look at that and then give you an update on your idea?
Because most places do. I think we could probably make that happen.
I think it would really help achieve this.
Having a focal point as a person who just, I think I can see the strengths in that.
Great, thank you. And there's also, there isn't a reference in the strategy for supporting and understanding those with dementia in the Black, Asian, minority ethnic communities in London. And there's evidence that suggests that some communities may struggle to access information, perhaps exacerbated by language barriers. Will you look at whether marketing materials in different community languages, and what might you perhaps do to help all communities who are affected by dementia in London?
Well, we are already targeting some of our work. It's a question that Dr. Zahota asked in relation to reducing inequalities versus improving health for everyone. And we are already targeting some of these policies towards those communities. Yvonne.
Yeah, I think this is a really good topic because we don't have much data about dementia in older Black and ethnic minority group, but we have a significant ageing, particularly Caribbean group in London, and we would expect therefore to see at least proportionate but possibly disproportionate because of cardiovascular disease. So this is an important area where the data are lacking, and I think having a champion will help us perhaps find some of those people and understand a little bit more how we can do better for them.
I think it's really important, and some communities there's stigma around this. It's understanding it and how we get behind the data to target would be really good. We talked about transport being important in this area, and TfL has embedded the dementia awareness in its equalities training. Can you confirm whether this applies to bus drivers in London? And if not, is this something you would encourage all bus operators to roll out so that we do become this fantastic dementia-friendly
applies to the whole TfL family, including bus drivers as well.
So they're already included?
Yeah, and it's really important they are, because they are if you think about it, they are the front line to many people and stuff. And actually, when you do the dementia-friendly training, one of the examples they give is somebody using a bus, and the example is a very good one. And it's simple things we can do, from the announcements on a bus to a driver being aware, so I can let a passenger know you're arriving at your bus stop, and just make sure that that person gets off, because often you can be confused when you're a dementia sufferer. So that's included.
It's already in place. Brilliant. Well, I look forward to an update on the champion.
Thanks,
Thank you very much.
Assembly Member Devonish.
Good afternoon, Mr. Mayor.
Hiya.
How have you worked with the London Borough Public Health teams to prepare your strategy, please?
Well, I'll let everyone and Tom give the deals in relation to all the work we've done with quite a few stakeholders, not just that team, but in particular London Council's team.
So I'll start, Deputy. So when the consultation was on the go, we made sure that Directors of Public Health were in a position to put that to every Health and Wellbeing Board, at least for information, preferably for discussion, and the majority did. We've also worked very closely with Directors of Public Health and their teams throughout the process. They helped us shape the priorities for this, and they helped us understand some of the local inequalities, but also some of the local solutions. For instance, on suicide, we have an excellent audit to hand, and we have that kind of information for a range of other areas in the strategy about what exactly is going on locally and how best practice could be shared as we implement. We're also very mindful of what the local authorities can and should do versus what City Hall can do. And sometimes this is important, that we don't disempower local government by assuming that everything happens at a city level. It certainly doesn't. So we operate a public health system in London.
And so we've met all the Health and Wellbeing Board chairs, and each Health and Wellbeing Board has to have an annual kind of strategy about how it's going to implement its plans locally. And what we've asked and they've agreed is to look at what's in the GLA Health and Equality Strategy to see which bits of that can they therefore implement. And what they've asked for is, can we actually give them best examples of where it's already been done, rather than having to start from scratch. And so the example again I'll use is the early years, the healthy early years. Where they want is a nice, easy to implement system. They can just take it, not quite off a shelf, but use it in a borough of Brent or Bromley and say, how can we roll that out to every single setting in our borough? And so I think they're quite engaged in it because they see it quite easily applying to their borough, and they just want ways to do it very easily.
So when I was first Public Health Cabinet member on Westminster Council, we had very simple, high level, such as reduce smoking, and then a whole lot of detail from people like you, how to actually do it. Reduce obesity, ditto. Reduce STDs, ditto. What I'm not picking up here, really, I'm not really clear exactly. You're talking about lots of signposting, I understand that, lots of what we used to call nudging, but what I'm not really sure of is where are we now and how are we going to measure where we're getting to at the next, dare I say, election in 2 years, or the year after that, or the year after that. It's not clear in terms of, we all agree there's health inequalities and they need to be addressed. It's how exactly you're going to get from where we are now to where we're aiming to get to in numbers that we can easily measure you on.
Can I say, I'll let Professor Doyle answer that, but to be fair, you've actually articulated one of the problems with the health and social care ecosystem in London. It's very complicated. So in yesteryear, we'd know who was in charge, what the responsibilities were. Now the number of partners involved are numerous, and it is confusing, not just to practitioners, but to Londoners as well. And that's why in the draft strategy, the Health Committee were small c critical, because they were saying, we're not clear, I'm paraphrasing for the benefit of the committee, not for those not in the committee, we're not clear what are things you will do, what are things you'll call upon others to do, and how do we measure success. And that's one of the things that Yvonne and Tom have gone away with and worked on. And at the last Health Committee, Yvonne and Tom went through the implementation plan to answer your question, which is a question that the Health Committee have been grappling with. So I'll pass over to Professor Doyle to deal with that.
So I am absolutely, I'm clear that am I actually being heard at all? What do I do?
They'll let you know if you aren't, I can assure you.
I see something waving at me, sorry. I get this entirely, this point about numbers. You want to see what we're doing and how you'll know if we've made progress. And to some extent, some of the, sorry, I'll just keep going. Some of that is in the population health indicators data, because we've spent some time working out what the gap is. We can put the numbers on that and, give you data year on year that is reliable at least. The targets we should also be able to give you data on how we're progressing towards those targets. Some of the dates are a bit far up, but we want to see improvements year on year, and if we're not making improvements, we'll say so and we'll explain ourselves as to why and what we could do better. So I do assure you that I think the way we've set up the indicators, we'll be able to give data.
And giving a very clear example, so at the moment, let's say there's a 9.8% gap between those children on free school meals and the general population about how ready are they for school. It's a measure we do kind of yearly, and therefore implementing the early years health setting project, that should have an impact to reduce that difference. So therefore children on free school meals are more ready for school than they are now, because we're doing a universal project but targeting at those boroughs with the most children on free school meals.
So if you had to name 3 major step changes you'll make by the election after next, so 2024, one's going to be free school meals, what are the other 2 going to be?
The early years health setting, not free school meals.
So we don't do the free school meals, but the way it works is it's a metrics in relation to school readiness, sure. So it's one of the indicators. And so different health inequalities, the gaps have different indicators. And I think one of the things that we're quite keen to work on is the Healthy Early Years programme. And that's the target is 10% take up within 2 years. We would hope to see progress in relation to that going forward. The other thing you'll know, we've appointed a very good chair and vice chair. They've got a team together around the Child Obesity Task Force, and you'll also have seen the work we're doing on the draft London plan and other policies around, for example, new takeaways not being within 400 metres of new takeaways of schools, but also advertising around foods high in fats, sugar and salts. We'd want to see progress in relation to those two areas in particular. You asked for a third one, and the third one is in relation to, in answer to the question that Dr. Soter asked, mental health amongst young people. Now, you'll be aware that we've got no control over the time lag between a young person seeing a GP and being seen by CAMS. It's not within our gift. What we can do, though, is to train up first aid mental health experts in schools. And that's a way of making sure it can be identified earlier. The good news is the government wants some of London to be trailblazers in relation to some of the work they're doing around mental health for young people. And we're optimistic that will lead to us raising our game there. We hope to add value there. Some of this, the question you asked, your first question was sort of cause and effect. What things can we point to and be held to account for? It is difficult because there are a number of different fingers in the pies, but those three ones are probably the ones we think are most pressing and the ones where we can add value.
Okay, I'll leave it there. Thank you.
Thank you very much, Chair. I want to come back to the subject of air quality and also the issue a bit of targets. I think you've done more than almost any other politician in the country, Mr. Mayor, to get air quality onto the agenda for Londoners and actually also nationally. And I think you've done that by regularly discussing air quality despite everything else that's been going on in London, but also by releasing so much detail. And it's great to see it's covered in the strategy. And we've already seen the T-charge. We've got the ULEZ coming in from April next year and then expanding in 2021. And I just wonder the target in the implementation plan of, you know, London to have the best air quality of any major city by 2050. I mean, in June, you held a big session on National Air Quality Day talking about taking action much sooner. That seems like a date a long way away. Could we not bring that date forward? And also, should we not have some interims after the 2021 expansion of the ULEZ? You know, we're going to be on a journey towards that. 2050 is a long way off.
Absolutely, and the prevention partnership that Professor Doyle chairs will on a regular basis be monitoring, reviewing and reporting back on the progress made. You'll be aware, because your constituency has benefited from the low emission bus zone in Putney High Street. And so we've already seen improvements across London in relation to those schools that have had an air quality audit, those schools getting support to improve the air quality, but also in relation to those parts of London which have the worst air getting the low emission bus zones. You'll also be aware that actually from April next year we'll have the ultra low emission zone in central London. And so we're hoping to see incremental improvements over the course of the next few months and years, let alone 2050. So rest assured that Professor Doyle will be reviewing this and reporting back on this regularly. It's worth just saying this, we're also doing groundbreaking work in relation to auditing nurseries and also looking at the quality of air indoors. You will know that most of us who are indoors breathe the air that comes from outside. Question, can we have filtration processes that improve the quality of air indoors as well as improving the air outdoors, which improves the air indoors? We're doing some work around that as well. But I want you to be reassured that we're not going to wait to 2050 for me to celebrate the successes as the Mayor over the last 30-odd years. Professor Doyle will tell you some of the things we're going to do in relation to before then.
I certainly hope not, because I will be very, very old by 2050. So what we would want to do, this is where the population indicator is actually close to what we look at each year. So we're looking at the proportion of illness caused by particular parts of air quality, and we measure this rate, we measure it regularly so we can say that, and we're also going beyond that and looking at where there are legal exceedances. So that's really what we'd want to be accounting for regularly. Just going back to the previous point about where are the numbers, and some of the targets are very good on numbers. You know, they'll tell us we want to do 1,300 schools by such and such a time. But for air quality, because it's a big process of changing over the traffic and the fleet and everything else that contributes, it's much better to measure the population indicator on that to account adequately.
It's just I'm aware of the impact, and Mez just mentioned Putney High Street and the
Yes.
change in the number of exceedances, which, you know, a couple of years ago was 1,600, down to a much lower level, and we didn't even break the law in Putney High Street. Normally by the 2nd or 3rd of January, we almost got through to April this year. So it's quite a dramatic improvement. So I'd quite like to see a target earlier than 2050,
Yes.
but I do understand where you're coming from. Can I just ask, actually, you were talking about the schools, and there's been targeted work around that. We've also had the Mayor's Air Quality Fund, and we've got the next tranche coming out. Could you tell us a bit more about targeting towards the more deprived communities? Because I think that's another really good way, as well as doing the air quality checks around schools in deprived neighbourhoods.
Before I do, just worth reminding ourselves that only half of the nitrogen dioxide, particulate matters comes from transport. The other half comes from things outside our control. So it's worth to bear that in mind. It goes back to a good question asked by Senator Devonish about how we can attribute successes to City Hall versus local authority or central government, all the rest of it. And we're lobbying the government for more of these powers and resources as well. In relation to the next tranche of the Mayor's Air Quality Fund, we are trying to make sure we help those schools access the funds to improve the air around the schools. You'll be aware of councils having responsibility of some of the LIP funds and money's involved for them. We're hoping schools will work with the local council to get some of the monies from around there. In relation to other things we're supporting is greening. Urban greening in particular is really, really important. We've released a new tranche of money for tree planting. You'll see the fantastic week we had in July around National Park City Week as well. Separately, not linked with this direct pot of money, is the work we're doing around fuel poverty. I know you've been lobbying as chair of your committee about the importance of fuel poverty. The good news is we're going to carry work in relation to making sure homes are energy efficient, really important, and carrying on some of the work we're doing around old boilers as well.
Well, thanks very much for that, Mr Mayor. That's all really welcome. I just thought I'd quickly ask at the end on the government's Clean Air Fund, is there any progress at all? Most of the roads in London should be included in that fund. Extra vehicle excise duty, we all pay vehicle excise. Any chance of us getting hold of any of that money?
Well, first, I think it's worth giving credit to Michael Gove for attending the summit we held in London. You know, and so the Secretary of State heard about the summit and asked to be invited, which I think is refreshing. He listened and he engaged as well. What he's agreed to do is to be, if you like, our advocate inside Cabinet to lobby the Treasury and others for the reasons, transport and others, for some of the things that we need to have. One is, for example, we need to make sure London can access the Clean Air Fund. We contribute towards it via the VED contributions if we can't access it, but also 40% of the most polluting roads in the country are in London. And there are other examples of government policies that are anti-London. And so we're hoping that Michael Gove explains to colleagues within Cabinet why it's important for some of these policies to help London rather than having London be neglected by central government policy.
Well, I think we'll, as an Assembly, have to cross our fingers and hope that some of that money is able to come towards us, because we need that support for the work that you're doing. Thank you, Chair.
Assembly Member Bailey.
Afternoon. I'd like to go back and focus a little bit on mental health. Much of this conversation has talked about targeting. What specific targeted support are we giving to groups in London that suffer higher levels of mental health? I'm thinking of the LGBT community, the black community, BAME community. What specific pieces of work are being looked to support those communities?
Good question. You'll be aware there's a disproportionate number of those communities suffering mental health, and I'll let Yvonne and Tom give you some examples of the targeted money. So this is over and above the Thrive London work we're doing and the mental health work we're doing. And there's work around rough sleepers, young people. I'll let Tom and Yvonne deal with it.
So if I may start first of all with rough sleepers. So what we do know is that a high proportion of people who are sleeping rough have both either a drug and alcohol problem or a significant mental health issue. So there's been funding allocated from the Mayor to fund workers with a mental health qualification to specifically work with rough sleepers to see can we address not only their housing issue but also their mental health issues, because often without addressing both you get a vicious cycle of a person being given accommodation but then unfortunately collapsing back into a lifestyle which made them homeless in the first place. So that's trying to have that much more holistic approach to rough sleeping and the medical problems aligned to it. Secondly, when the police, what they find out when they're involved in dealing with the public who've potentially committed an offence, that often the person who they're dealing with has got a probable and obvious mental health problem. They often have only got an opportunity either just to take them to the police cell, but in fact now we're funding workers to work with the police at their key hours, which is usually from kind of the afternoon right to midnight, so the police can call out a mental health professional to work with them on a person who in fact has probably got a significant mental health problem, more than an issue regarding committing a crime which requires taking to a police force, and then they can work with that individual to take them to either a place of safety or to one of the psychiatric decision units or to see a mental health professional. So there are two targeted areas: rough sleepers and people who the police are apprehending in the community.
I'll give you one more example, Senator Bailey, is the Young Londoners Fund. We've targeted some of the Young Londoners Fund towards Young London Inspired. And what this is, Professor Doyle alluded to this, but the idea is to increase volunteering and social action opportunities for those young Londoners who are at risk of developing mental health problems. And the wonderful thing I've already alluded to is in relation to the work we're doing in schools and speeding up referrals to see somebody short of CAMS if there's a CAMS waiting time.
They're all welcome examples, and I commend you, truly I do, but the strategy itself doesn't make it clear how particular groups, particularly the ones I mentioned who have really high instances of poor mental health, will be targeted. Where will they find the work? Where is the work stream, where's the money stream? It'd be much more helpful if it was clearer about those things, because it leads to the obvious question: what does success look like, and how do we measure it? Because for particular groups, again, LGBT groups, BAME groups, their access to mental health work is slim, to say the least. So we need to understand what is impactful so we can do more of it.
Can I mention the work of Thrive? Which, so first, I mean, Yvonne will mention Black Thrive, which is particularly focusing on the black community in London. But what you also are aware of, there are a number of communities whereby the stigma of mental illness is much higher. And one of the work that we want to do with the Thrive kind of work stream is to say, how can we work through all communities? So, because often the first thing one's got to have to accept is that, I'm unwell. I've got a significant mental health problem. I need to admit it and seek help. And what we find is when you look at people, unfortunately, committing suicide, and there were 12 Londoners this week who will probably commit suicide, what you find is they did not want to tell someone about how they felt. And it might be stigma or access to services. So we would hope that Thrive, and especially Black Thrive, will work with our communities to reduce the stigma, to allow people to have rapid access to services which can help.
I understand that. I just would like a little bit more focus on how do we measure that success? How do we know what we want to replicate, what we want to put down
So
to didn't work?
let's talk about the implementation plan, yeah.
Yeah, so I mean, Deputy, the implementation plan will actually look at the indicators that we have, some of which are very related to mental health. So, for instance, those in employment with long-term conditions, the commonest reason for people falling out of employment is because of mental health problems. So we try to see how various programs that are focused on better work and better quality of work. The City of London are working with us on that. I'm very keen on the work we're doing with schools, because 70% of mental illness is actually beginning to manifest before the child leaves second level schools, and we know that black and ethnic minorities and not the same thing, more deprived communities both suffer disproportionately here. I think one of the issues we found from our learning from HIV is that people have difficulties dealing with the stigma of some of these conditions, and some communities do not recognise mental illness the way it's recognised, say, within the mainstream of the NHS.
I see that, but my real disappointment with this part of the strategy is there's no clear line of what we're doing for vulnerable groups. There's no metric around what are we looking at, because what's very interesting is how do we replicate the good work? What is good work? Okay. What does that look like?
So can I try and answer it? So if I just look at metric number 6, which looks at excess mortality amongst adults with a serious mental illness. so per 100,000. So what we're saying here is that there are in London, there are 327 people per 100,000 with a serious mental illness die more than they should compared to the rest of London. So that is your health inequality stats. So what we want to see, and we're going to measure the number of people with a serious mental illness who die per 100,000 and reduce that number from what it is now, which is 327 greater per 100,000. So that's our indicator. Now that looks at both physical illnesses and mental illnesses. So a person with a serious mental illness, let's say schizophrenia, in fact, they're just as likely to die more frequently from cardiovascular illness than, in fact, suicide. So we are measuring it.
I see that's correct, but that still doesn't look at what we're talking about, particular highly vulnerable groups. What you're talking about is our general population, and of course, we welcome support in everybody's health. But I want to know what we're going to do specifically for those groups, and I maintain it's not in here. I get that you can't answer that, but somebody needs to put it in here because of your 300,000 people that you just talked about. A disproportionate amount of those people will be LGBT, will be black, will be for the traveller community, and unless we do something specifically for those communities will just suffer disproportionately even more. And I just need to see some indicators of what we're going to do, when, what the metrics are, and how.
Yeah, I think that's absolutely reasonable, and we will take a note of that, Deputy, to see do the data exist in that way. Sometimes, it's not available, but definitely. And to answer your question about how we share practice, I mentioned earlier we've just got a very good suicide audit. Thank you. And the suicide audit actually gives us examples from practically every borough in London about good practice. And much of that is aimed at specific groups where an intervention made a difference, and we're sharing that across.
Thank you. That's enough from me, Chair. Thank you.
So remember the sigh.
Mr. Mayor. So looking very specifically at the issue of knife crime, what are you doing to improve collaboration between the Met and the NHS in this area?
Thank you for your question. I mean, I've said for some time now the issue of knife crime is not going to be solved by the police or the criminal justice system by themselves. And you're right, there needs to be collaboration, not just between the NHS and the Met, but other partners and the Met as well. Schools, social services, probation, youth services, community and voluntary groups, parents, civic groups as well. In relation to just the NHS, a number of things that is taking place now from the NHS, which we welcome. They're involved in early years, they're involved in therapeutic services, they're involved in crime reduction partnerships, they're involved in the London Health Board, and they're playing an active role in relation to all the policies that we're embarking on in relation to the knife crime action plan. You'll have heard the phrase, which has become sort of zeitgeist now, public health approach. Well, the idea of a public health approach means basically, addressing the issue, the specific, trying to stop it spreading, really, really important, and looking at the root causes. And the NHS clearly has a role to play here as well. We've engaged an experienced Director of Public Health to help us in relation to a public health approach. And you'll also be aware, because you've lobbied for this, is the increased investment we've given to major trauma centres and some of the A&Es now from groups like Red Thread and St Giles. These are youth workers who are in the NHS area, and they can speak to a young person who may have been involved in, maybe the victim of knife crime, that teachable moment, to prevent them, if they're involved in a gang, for example, that escalating, but also to offer mentoring and support. And as a community engagement team in City Hall, we're working closely now with not just MOPAC, but health, education, and youth services as well across London. That collaborative approach is really important.
You talk about public health, and can I just say that I totally endorse that approach. It is the right approach. But do you think you need to do more to sell it to Londoners? What does it actually mean in practice?
I think the issue isn't so much selling it to Londoners. The issue is making sure we've got the levers. So I've written recently to the Home Secretary, not simply asking for more resources, but saying some of the public duty levers that exist in Wales and Scotland don't exist in London. So I can't force, inverted commas, a local authority, somebody in a council, the NHS, to do things by persuasion and bringing them together. And with finite resources, often one of our partners may not deal with this issue as a priority. And so we wait to hear from the Home Sec, but we've got to do more to persuade Londoners. They have a role to play in stopping young people thinking it's okay to pick up a knife, a young person thinking it's good to belong to a criminal gang, a young person thinking a knife makes them safer rather than less dangerous. There's a whole host of things that we've got to be doing, and we are doing.
You mentioned MOPEC. So what are you doing to maximize the impact of the preventative work of MOPEC? They do a lot of it, but...
It's really important, the preventative side of the equation. So you'll be aware, one of the reasons why I announced a new pot of money, the Young Londoners Fund of £45 million, was to give young people constructive things to do in the context. Over the last 8 years, youth centres closing down, many of the preventative services are closing down. We've also invested an additional £8 million on Sports Unite, and also significant sums of money around youth workers in A&Es, all the other things that we are doing. We need to make sure we remember the second part of toughen crime, toughen the causes of crime. I'm not excusing criminality, I'm just making the point that lots of young people now who previously had constructive things to do haven't. We've got to invest in them rather than afterwards, once a crime's been committed, picking up the pieces.
And also there is some evidence to show that young people who get involved in serious crime are much more likely to have a diagnosis of ADHD or ASD, and often they're from a cohort in a community who don't necessarily access the mental health service to get that treated. So you often get young men with undiagnosed ASD, ADHD, who then get excluded from school and then ended up eventually with another cohort of young people in a similar situation, and then go on to get involved in serious crime. So I think there is a role for the health service to be much more proactive in identifying young men, particularly with ASD and ADHD, in a school-based environment, keeping them in school and treating that condition rather than letting it go untreated and then eventually arise in significant behaviour problems later.
And the final question, Mr. Mayor, in terms of, you talked of the youth service, and inevitably with the cuts to the youth services and children's mental health services, how has this affected the work of the Met?
It's had an impact because the Met, historically, the police would be the last port of call. Now they're the first port of call. The number of 999 calls from somebody or to do with somebody with mental health problems is huge. But also, we've had a case with one borough, did a case review of every single one of their cases where somebody had suffered a violent incident. Every single one of those young people had been excluded from schools. So it's all linked in relation to the police picking up the pieces. And that's why I make the point, the police by themselves can't solve the knife crime crisis there is in London. That's why we need a holistic approach, a public health approach. And I won't apologise for lobbying for more resources. I appreciate that some editors who are responsible for the cuts may not like it, but I'll not apologise for being an advocate for more resources in our city and making the point that those cuts should be reversed.
Thank you.
Thank you very much. Assembly Member Copley.
Thank you, Chair. Mr. Mayor, you and all members here, of course, are aware of the crucial link between housing and health. Your strategy states that 8% of London households are overcrowded. What assessment have you made of the impact of overcrowding on health, and what are you doing to tackle the issue?
Well, I mean, I'll let Tom and Yvonne deal with the issue of the link. There's a clear link, and they can explain the clinical link between overcrowded housing and health inequalities. You'll be aware from your experience as a councillor and assembly member the concerns young people have about not having somewhere to play, sharing a bedroom, not being able to invite your mates around, where do you do homework. But actually there's a link between overcrowded homes and poor health. When you say 8%, that reflects 250,000 households. And if you assume, for argument's sake, there are 4 people in a household, that's 1 million Londoners. So there's a huge, huge impact around...
And 22% of children.
Absolutely right. Yeah. Absolutely right. And we can't ever forget that. So a number of things that we are doing in this area. One is we want to make sure that the housing strategy regularly looks at the figures in relation to overcrowding. So on an annual basis, we'll be seeing at what position is in London in relation to overcrowding. Are our policies making a difference, positive or negative? The draft London plan now puts a requirement on councils to provide guidance to developers in relation to the mix of family homes. building family homes on market value won't necessarily address the issue of overcrowding. Why? Because currently only a third of family homes have children living there. The remainder have adults whose kids have left home, are homes that have been bought as an investment and are let to young professionals, or have other people living there other than children. So we need to make sure there are more affordable on low rent family homes. And so we're hoping the draft London plan with the guidance will encourage developers to build the right sorts of home. But also we need to make sure there are more smaller homes that are built so adults who are living with their mums and dads can move out of that home and live in a smaller property as well. But I want Yvonne and Tom to talk about the links between overcrowded housing and poor health.
Yeah, so the issue of child poverty and housing is actually related as well, because quite a lot of the children who are in poverty are living in rented accommodation, and the indoor quality of some of that housing is very poor, and that has a direct relationship to health, including their mental health. And that if that's in an environment that's adverse, or they're suffering other things like domestic violence, I mean, it's just, we then get the kind of problems we may be seeing later on that we've been describing with the gangs. So there are very direct links here. And the other issue for us is the change in the migration around London because of the cost of housing. So now we see outer boroughs in London receiving significant need and poverty and different population mixes that they have not been used to. So this provides a huge challenge to us. We work with local government anyway, very closely with directors of public health to ascertain how those needs are best met. But it's absolutely crucial that the support for families and the housing infrastructure and the plans at city level actually work to make this better, because we certainly do have a problem.
I'm glad you mentioned mental health as well, because of course, I mean, we all know, if you've got mould on the walls, it's going to have an impact on children growing up with asthma and breathing difficulties, things like that, but also the impact on mental health. For example, yes. If you're living in very tiny accommodation, and the impact that can have in mental health, or indeed in the private rented sector, perhaps having been forced to share a flat with people you don't like can be have a huge impact on people. I just wanted to very quickly, I've had that experience, and perhaps other people have had that experience with me, I don't know, but just to come back very quickly to you, Mr. Mayor, just on the size of properties. I know this is an area that you don't have control over specifically, but permitted development rights offers to residential, leading to these very small rabbit hutch homes, some of which are smaller than a Travelodge hotel room. And I know, I think you've been lobbying the government to get rid of those permitted development rights anyway. But at the very least, will you make the health case to the government that if they're going to keep permitted development, when prior notification is given, the minimum space standard should be a condition, that they should meet the minimum space standards?
Absolutely. We've been lobbying unsuccessfully so far in relation to the spread of permitted development, very least supporting councils around Article 4 to get some protection, and some of the quality of some of these homes is shocking. And you're right, there should be a minimum standard, and the design guide we help councils with has that. But around permitted development, you'll be aware that's a loophole which allows somebody, and they make huge money out of doing this, to turn office buildings into residential buildings which are completely unsuitable and not of a spec that any of us would want to live in.
And one of the most stark stats is meningitis is 10 times more common in an overcrowded house for children than the rest of the population.
That's an astonishing statistic. Yes, thank you.
Assembly Member Boff.
Mr. Mayor, with regard to overcrowding, is there a metric in your health strategy to address overcrowding?
There are policies in the draft on the plan, around the implementation plan. Give me just one more. In the implementation plan, you mean?
In the implementation plan, is there a metric on overcrowding?
No, there isn't,
no, there
because
isn't.
It's not one of the areas that we're specifically measuring. However, we do look at overcrowding in other ways.
Thank you very much. So there's no metric for seeing how we're doing. Mr. Mayor, what's in your strategy to address, to protect adult males who are most likely to be victims of violent crime?
In the health inequality strategy?
Yes, what's in the strategy?
Well, there's a number of policies in the police and crime plan in relation to stopping adults being the victims of crime.
but you do mention explicitly within the health and inequalities strategy, violence against women and girls, violence against children, but you don't seem to mention violence against young men who are the most likely to suffer violence against them.
I think there are policies in there in relation to alcohol abuse. I think Senator McCurtain referenced the binge drinking, and Professor Doyle talked about the consequences of binge drinking, which are around antisocial behaviour. Much of the time it can express itself in violence against men, which is one of the things that you're talking about. There's also policies in there in relation to knife crime. Again, the victims tend to be young men as well. I'll let Professor Doyle do with some more examples.
The prevalence, I'm talking about the prevalence of violence against young men. It just doesn't explicitly get a mention, whereas violence against women and girls and children does get a mention.
Yes, I mean, there are data about this. I'm sorry, I'm just trying to understand the question. You would like to have data on violence against young men from knife crime in the strategy? Is that
No, it's a violence against men. If you look at according to the crime survey for England and Wales, 2.1% of males compared with 1.3% females suffer from violent crime. And if you look at that group of 16 to 24-year-olds, they are much more likely to be victims of violent crime, 4.1%, than those in older age groups. But there's no specific metric and there's no specific mention in the health and inequality strategies of what is a disproportionate likelihood that those people will suffer from violent crime.
Yeah. So, Deputy, we are actually looking at how we can express the data about violent crime, particularly knife crime, but other crime as well, as we go forward. It's not
there, is it? I like these explanations, but it's not actually in the health and inequality strategy.
We're not trying to be unfair. We just want to actually make sure we start with measures that are reliable.
Okay.
And this is important in relation to your last question as well, because what the point about the health and all strategies and policies here is that we will, on overcrowding for instance, we will be working closely with the housing strategy to understand what that's telling us. There's lots of data on it.
With respect, they're not there. I mean, we know that those suffering with hepatitis C are a significant population, and yet there's no plan for action. We know that the mental health of BME, LGBT, deaf people and disabled are significant, but there's no mention in the strategy. And we know that violence against young men is particularly significant, and yet there's no mention in the strategy. Isn't it about time we went for yet another rewrite of this strategy to try and mention the people who need to be mentioned? And that's all I have to say. It's not really a question. It's just a cry of desperation, Chair.
That may be a speech from Hustings rather than today. I wish him more luck with the Hustings than today.
I shall issue a formal warning later on that this is not to be a substitute for hustings, but it's all good entertainment. The Conservatives are now out of time.
We're not.
Assembly Member Twycross.
No, we're not. We're not.
We've gone through most of the meeting without talking about Brexit, so my question brings us back to the main issue facing the country overall. My question is really around what you'll do to support the health services to make London a more attractive for the recruitment and retention of health and social care workers, given the fact we've got an ageing population and are likely to have a further reduction in access to EU labour, which we rely on quite heavily in London.
Well, Chair, I'm hoping the work the Assembly Member is doing with the London Resilience Forum in preparations for a no-deal Brexit will help answer that question for me. But let me tell you where we are. Where we are now is we've done some. We've asked for some independent analysis to be done of Brexit, which should worry all of us. There are roughly speaking 19,000 EU citizens who work in the NHS. They're Londoners, by the way. There are 13% of our social care workforce who are EU citizens. They're Londoners, by the way. And I'm very worried about not only what will happen if they decide to return to inverted commas country of origin, bearing in mind the hostile environment coming from this government's policies, but also the fact that in London we currently have, and it's worth reminding ourselves of this, a vacancy rate of, roughly speaking, 15% of nurses' positions. And that's why you should be really worried about what happens post-Brexit and also what's happening now in our city as a consequence of Brexit. Doctors in London who were surveyed, 86% of them are worried what will happen to the NHS post-Brexit. And that's why I've asked the London Resilience Forum to do some work in relation to us preparing for what happens when Brexit, if Brexit happens. You'll have seen the coverage recently about concerns about a shortage of medicines, but all sorts of other issues that could be in relation to Brexit. So we are worried. The London Devolution Board is doing some work around estates, the workforce, prevention and digital. And also I'm hoping that the online portal we're working on will give some comfort to those Londoners who are EU citizens about what their rights are in relation to the settled status scheme that the government's going to announce very shortly. But it is a source of worry. I, as a specific example, though, have recently been involved with an initiative called the Capital Nursing Campaign. And this is a great initiative from the NHS and the Royal College of Nursing, encouraging people to apply to be nurses in London, encouraging Londoners to apply to be a nurse and train to be a nurse. Because we need to make sure that we don't have a situation where the combination of EU citizens leaving, EU citizens not coming, but also Londoners not wanting to be nurses and join the NHS leads to a real problem in the future.
Thank you. One of the issues I just want to highlight with you recently came up over the summer in some of the newspaper reports about a report by the Department for Health to the Migration Advisory Committee that warned that a decrease of EU workers in the social care sector would potentially lead to an increase in women staying at home to care for relatives. And I just wanted to ask you whether you had any thoughts about what the government could do to avoid this, because clearly it's unfair that women would pick up the slack for the government if they're unable to resolve this issue in the context of adult social care and Brexit.
Well, you'll be aware of the in-work poverty there is. People who are working and are in poverty, often, it's important for somebody's self-worth and dignity to fulfil their potential to go and work. And the idea that we could be going backwards as a consequence of policies from politicians is heartbreaking. You'll also be aware of the phrase used about the sort of the sandwich generation, those people looking after their children, but also their parents as well. It's a phrase we used previously in relation to healthy life expectancy, and it's a big source of concern. And my worry is, as a consequence of these policies, not only does it lead to the individual who's having to stay at home to provide adult social care, not fulfilling their potential, but it leads to huge damage to our economy in London as well. That's not a primary concern. The primary concern is the individual. And that's one of the reasons why you'd hope the government would be thinking through the consequences of policies that are fixated by ideology and dogma rather than what's in the best needs of our city and our country.
Thank you.
Assembly Member McCartney.
Yes, Mr. Mayor, I want to return to social prescribing, if I may. And your strategy makes it clear, and I'm quoting from the strategy, that its success depends on a strong local community and voluntary sector. So can I ask, what are you aiming to do to support the community and voluntary sector, particularly in areas where it's at weakest and it's probably most needed?
Yeah, we've done some good work on the London Health Board on this, but I want Tom to give you an example of the work in Tower Hamlets that will just show you the difference it can make and what difference good leadership from a council with the local NHS can make as well.
So Tower Hamlets is one of the first boroughs in London which really piloted social prescribing a couple of years ago, and it worked out that for the CCG invested about £1 a patient, so it's about £300,000 to cover every single general practice in Tower Hamlets. So every single GP and nurse within that practice can have a system to prescribe social prescribing to the patient in front of them. That money then paid for a number of what's called navigators who the patient would go and see to talk through their issues. And also, the local authority also then made sure that it could support the voluntary sector, because what it recognised was that by investing in social prescribing and making sure your most vulnerable had a level of input that would keep them at home, keep them out of social care and out of hospital, was an investment worth making. So if you can get the CCG and the local authority working together, the voluntary sector often has the volunteers who are trying to come into the system, and we in the GLA can assist directing volunteers into the system. We also in the GLA can work with the wider London structures. Myself and the Mayor recently met the Bishop of London, who committed to trying to use her kind of powers to try to coordinate the offerings throughout the Church of England in London, to have a directory of services that we could refer into, which are often untapped. So there's a whole array of services out there with minimal investment, which can have dramatic benefit, using the GLA as almost a vehicle to driving all these partners forward.
And the other potential, which I'll ask Professor Doyle to talk about, is the issue around social impact and commissioning. So can the NHS help voluntary community groups get some of the resources they need in this area?
Because I've read about that and I'm very short on time, so but I'm very interested to hear that, and I hope the GLA will be urging other local councils to develop that. But my other question was going to be about a social prescribing register, and will you try and work with, you said the Bishop of London, local councils, to establish a social prescribing register so GPs know the organisations that are out there that can help?
It doesn't work otherwise. It's really important. Yeah. I mean, part of the vision for social prescribing is this database. So a GP, somebody knows where to signpost people to, and it's got to be reliable, accurate, and you know, so the GP can have confidence signposting somebody away.
So we are going to work on that. Thank you.
Assembly Member Hall.
Mr Mayor, I'm beating the same drum here. FGM is a real health steer on this. It doesn't even feature once in this strategy. Why does it not feature at all?
Okay, can I just say, Chair, the previous question from a Conservative member criticised me for having too much focus on violence against women and girls and not enough in relation to men, I think was the concern.
No,
I don't think
if you could just
Assembly member
answer
was
my
concerned
question, Mr Mayor, please.
that men were suffering disproportionately. So on the one hand, I've been criticised for having too much focus on violence against women and girls. On the other hand, I've been criticised for having not enough focus on
Mr.
violence
Mayor,
against women and girls.
running out. Can you answer my question?
I'm unclear what is the criticism.
I take that criticism on, but this is one of those rare occasions we've been asked a straight question. Yeah. Why haven't you done something? Perhaps you'd like to answer that.
Yeah, of course, Chair. The policies we have in relation to violence against women and girls is quite explicit about some of the things we're doing around FGM, female genital mutilation. Now, if it's the Assembly members' wish for a health inequality strategy to be a compilation of all the various strategies I have, I think that'd be a very, very dense document. What we've tried to do with the health inequalities strategy is to focus on the issues that we've talked about during the course of this afternoon, to focus on the issues we've talked about, the advices to the Health Committee, and to address some of the points made. And I'll tell you this, Chair, I'd have more sympathy for the contributions from the Conservative group if they'd bothered to respond to the consultation. No. They couldn't even be bothered to respond.
Mr Mayor, I do strive to be objective. This was a question from a member. To simply say it is a Conservative member or a Labour member suggesting that they're running some sort of separate agenda, don't think is an appropriate way of dealing with that. No doubt the member will think of another way of asking the question on another occasion. Mr Boff.
Chair, I was referred to earlier by the Mayor. I specifically did not criticise the inclusion of violence and women and girls in the strategy. What I criticised was the exclusion of violence against young men. That is a completely different thing, and you misrepresented my view.
Okay, you've made your point, Assembly Member Boff. The final question is from Assembly Member Eshalomi.
Thank you, Mr Mayor. And colleagues have already touched on the issue of mental health in young people, and especially mental health with young offenders and people in the criminal justice system. One of the things I wanted to look at is fantastic work of Thrive and definitely Black Thrive, which is a big issue in the two constituencies I represent. Just to ask a simple question, in terms of a number of people who we have seen unfortunately lose their lives whilst going through police custody, and there have been issues of mental health associated with that. And then the other issue of ex-offenders in the probation system caught up with mental health. Will you consider lobbying ministers to make sure that you actually get control of mental health services for ex-offenders as part of the probation service to come under your remit?
Thank you for questions. We've had good conversations with the Ministry of Justice around devolution on this area. As you'll be aware, the probation services in London are in crisis, caused mainly by them being privatised by this government against advice a few years ago, and the CRCs are having real problems. And so one of the things we've been talking to the government about is how we can assist them, bearing in mind we know London better than civil servants in Whitehall. One of the things the reason why you asked your question, I suspect, is you'll be aware that a significant number of those who are in prisons or YOIs have complex mental health issues. Dr. Coffey alluded to those who come into contact with the police, the Section 136 pathway, where people in the past have ended up in police cells rather than in hospitals elsewhere where they need assistance. We want to work in this area, and I'm keen to work in this area. And so when I meet with the Justice Secretary next, I'll make this point that actually not just the Mayor but the Assembly also agree, and we've got the expertise to do some work in relation to this area. Just to give you one piece of good news, is one of the things I did this year was to, when it came to funding the MPS, Met Police Service, £3.3 million of the funding we gave them is being used for the various basic command units across London to have mental health support to help the police do their job, because as you know, there are too many people with mental health issues get into contact with the criminal justice system.
And just on that, I think the other thing, not just the stigma of people who have mental health and not wanting to seek help, the other flip side of that is the reality and the fact that a number of people don't actually have adequate mental health training. Is there anything more that you think that you can do to work with different partners and groups to actually improve that mental health training?
Absolutely. I mean, Tom will give you some examples of the work we're doing. So just so you know, I've myself had first aid mental health training, and I'd encourage we're trying to make sure every floor in City Hall, somebody's mental health first aid trained. We're going to lead by example. The Lord Mayor for the City of London deserves huge credit for the work he's doing, Charles Bowman, in relation to reducing the stigma in the city. It's really important we reduce the stigma. There are 2 million Londoners with adverse mental health, and we need to make sure they realise they're not by themselves, and we're doing lots of work which Tom will talk about just briefly.
So for mental health first aid training, very much the philosophy behind it is if you're in a building like this, every single floor you'd probably have someone who's St John's first ambulance trained. So if someone falls over, hurts themselves, that person will be called to. In fact, in most places of work, most places in society, people, get ill much more because of a mental health issue. So mental health first aid training is meant to give people the skills to deal with a mental health crisis in their community, in their workplace, and principally the police force. So how can we make sure that people throughout London who are dealing with the public all the time have the appropriate skills to identify mental health crisis and to know what to do? Because too often people respond in a way either taking them to a police cell or taking them to a place which isn't good for their mental health. And that's why Sadiq has put mental health first aid training as one of his priorities for his health and equality strategy.
Roll them out in schools as well across London.
That's fantastic. Thank you. Thank you, Chair.
Thank you very much. We've now reached the end of this session. Thank you so much, Mr. Mayor and colleagues, for attending.
Thank you.
Now it's part B. We now move to debate the motion on the agenda set out in my name that the Assembly notes the draft health inequalities strategy. In a moment I will ask members whether there are any amendments to that motion or any other motions to be moved. Can I remind members that in accordance with Standing Order 319F and the provisions of Section 42B of the GLA Act 1999 as amended, any motion proposing rejection of the strategy requires at least 2/3 of Assembly members present and voting to vote in favour of that order to be carried. Abstentions do not count as a vote against and so are excluded from the calculation of the 2/3 majority. Any other motion requires a simple majority of members to be carried but is not binding on the Mayor. Is there a seconder for that, please? Thank you very much. Are there any amendments? Thank you very much. Are there any other motions? Thank you very much. In that instance, the Assembly has noted... I beg your pardon? Yes.
Contributions to debate first.
Thank you very much. I need to put that to the vote and then go to an explanation. Those in favour of my motion, please, to note the strategy. Good, good. Oh, really? Okay, those against? Well, the assumption I'm making is that everyone else is abstaining. The motion is carried. Thank you very much. Okay, that means, yes, thank you very much. Right. The motion in my name to note the draft health inequality strategy has been agreed. The Assembly has not exercised its powers under Section 42B of the GLA Act 1999 as amended to reject the strategy. And therefore, that concludes the Assembly's consideration of the draft health inequality strategy. Thank you very much. Now we go to the date of the next meeting. The next meeting of the Assembly is scheduled to be the plenary meeting of the Assembly on Thursday, the 6th of September, here in the Chamber at 10 a.m. The meeting will principally be used to hold a question and answer session with the Chair and Chief Executive of the London Legacy Development Corporation regarding the work of the LLDC. However, in addition, following discussion with the Mayor's office, that meeting will also be used to hold a question and answer session with the Mayor, representatives of TfL and representatives of Crossrail Limited to discuss the delay to the Crossrail scheme. Business the Chairman considers urgent. There is no urgent business, and I am requested to bang the gavel.